picture that we are looking at is a structure of the peripheral nerve. The smallest element in the peripheral nerve is an axon. Axons can be myelinated or unmyelinated. Myelinated axons will have Schwann cells covering them and have node of Ranvier in between the Schwann cells. These axons, whether myelinated or unmyelinated, will be covered by a layer of connective tissue layer called the endoneurium. These axons will all group together and form a fascicular bundle, and this fascicular bundle will be covered by another layer of connective tissue layer called the perineurium. The perineurium is made up of tough epithelial sheet, consists of collagen and fibroblasts, which make them impermeable to any potential toxins such as our local anesthetics. And then the fascicular bundles will group together and they will all be covered by an outermost layer of connective tissue called the epineurium. Epineurium, in contrast to perineurium, they are permeable. So local anesthetics can actually diffuse through the epineurium and enters the peripheral nerve. Other structures that exist inside the epineurium, other than the fascicular bundles, are the blood supply of our peripheral nerve and also some loose connective tissue like the adipose tissue. The blood supply to the peripheral nerves are called the vasa nervorum. They form the extrinsic supply outside of the perineurium, but within the epineurium, and they consist of arteries, arterioles, veins. Whereas inside the fascicular bundles, there are endoneural vessels that are in charge of intrinsic blood supply to the individual axons. Now that we have some knowledge of the structure of a peripheral nerve, we should apply it to our peripheral nerve blockade. An injection outside of the epineurium, which is the outermost layer of our peripheral nerve, is called an extraneural injection. In some nerves, like a large nerve such as our sciatic nerve, will have another layer of connective tissue outside of the epineurium, and the potential space formed in between the outermost connective tissue layer and the epineurium is a potential space for us to inject, and this space is called the perineural space. If you inject inside this perineural space, the local anesthetic can actually diffuse into the epineurium and give its effect. What's the difference between giving it in the perineurium and giving it inside the epineurium is that both of them will provide the same effect, because if you inject in the perineurium, they will eventually diffuse into the epineurium. However, if you inject inside the epineurium, it can actually cause a pressure injury within the epineurium, and this pressure injury will eventually lead to ischemia and so on. And this increases the risk of nerve injury. Now, if you inject inside the epineurium, it is called an intraneural injection. An intraneural injection can be outside of the fascicle, which is called extrafascicular injection. This is if we do not breach the perineurium. However, when there is a breach of perineurium into the fascicular bundle, then it is called intrafascicular injection, and this will increase the risk of nerve injury. Some nerves For example, the more proximal nerves when compared to the more distal nerves, they will have a higher ratio of neural tissue compared to non-neural tissue. This higher ratio of neural tissue will increase the risk of nerve injury if you inject them inside the epineurium, because there is a higher chance for you to hit the vesicular bundles. However, if you do an intraneural injection in the more distal nerves, then there is a less chance for you to inject into the vesicles and cause a nerve injury. This is why if you inject, if you do a peripheral nerve blockade at the brachial plexus, it increases the risk of nerve injury.
Peripheral nerve injury. So the classification, there's two main types, which is sudden and Sunderland type. Sudden is more commonly used. So for sudden, you can see from the table, there's neuropraxia, neuropraxis, and neuropraxis. So for neuropraxia is when there's damage to the nerve. However, it is only limited to the myelin sheath, and the rest of the nerve architecture is intact. So it could be due to excessive stretch or nerve compression. And as you can see from the table, neuropraxia is associated with the best prognosis as compared to other classes. And recovery is usually expected within weeks to months. Axonotmesis is when there's loss of axonal continuity, but there's conservation of the endoneurium, perineurium, and epineurium. However, Sunderland further divides it into 2, 3, and 4, depending on the involvement of the other architecture. So, for example, for Sunderland type 2, there's introduction of the axon. However, there's conservation of the endoneurium, perineurium, and epineurium. Whereas Sunderland type 3, there's endoneurium disruption. And Sunderland type 4 is when there's endoneurium and perineurium disruption. So the recovery varies, and it is dependent on the severity and extent of the injury. And recovery can be prolonged and incomplete. So the last one is neurotmesis of Sunderland type 5 is the most severe one, and it is associated with poor prognosis, and it occurs when there's complete transection of the nerve, and usually it requires surgical intervention. So how does peripheral nerve injury occurs? Pathophysiology can be divided into 4 main groups, which is mechanical, chemical, vascular, and inflammatory. So the first one, mechanical and injection injury, are due to traumatic injury. It could be due to partial or complete laceration of the nerve. It can even be due to when for example, we're doing a peripheral nerve blockade, there's a forceful needle to nerve contact, which causes perineurium disruption, and this leads to a direct axonal injury. And if interrupts the vesicles, it can cause leakage of the vesicular content and leads to inflammatory response. Or if there's direct intraneural injection, so a direct injection of LA can cause LA-induced chemical neurotoxicity. Or if there's high intraneural pressure, this can causes that the high ability to exceed the capillary occurrence pressure, which disrupts the blood flow and causes nerve ischemia. So these two diagrams just to illustrate the difference. So as you can see from diagram A as compared to diagram B, diagram A, the nerve actually has more connective tissue as compared to the nerve in diagram B. So even though when there's needle, the needle actually disrupts the epineurium. However, we can see because of the abundance of the connective tissue, there's no disruption of the vesicles. Compared to diagram B, there's less connective tissue. So when there's interruption of the epineurium. So the needle can easily damage the fascicles, and this can lead to a greater severity of nerve injury or nerve in the diagram B as compared to the nerve in diagram A. So generally, as we go, natively as we go from proximal to distal, there'll be more connective tissue within nerve as we go distal as compared to more proximal location. So there's also a decrease in risk of peripheral nerve injury as we go more distally. So how does neurotoxic injury occurs? It could be due to direct injection into the nerve itself or to the adjacent tissues. And so because of this, that can lead to acute inflammatory reaction, or this inflammatory reaction can go for long and causes chronic reaction and subsequently leads to chronic fibrosis. All commonly used local anesthetics have the inherent properties of becoming mild toxic, neurotoxic, and cytotoxic effects. And all these our LAs can causes fragmentation of DNA and uncoupling of oxidative phosphorylation, which subsequently lead to cell apoptosis. So because of these inherent properties, the neurotoxic effect of our commonly used LAs, so whatever LA that we use, if we somehow injected intravascular, it can cause peripheral nerve injury. So the site of the LAF may be the primary determinant of causing a peripheral nerve injury. Ischemia is when there's disruption of blood flow to the nerve itself. So 50% of the peripheral nerve vascular supply comes from this network of capillaries known as vasa nervorum. So if there's disruption, for example, due to direct occlusion by acute hemorrhage due to injury or vascular injury, or there's formation of hematoma, which causes mechanical compression of the vesicles, which causes disruption of the blood flow, or it could be due to too high injection pressure. This can all lead to disruption of the blood flow to the nerve and causes, when there's disruption of blood flow, it can cause ischemic injury. And LA and angina can also causes vasoconstriction and reduces neural blood flow. So next one is inflammatory injury. So non-specific inflammation can occur either at the site of the surgery, or the site of injection, or remote to the site. And this inflammatory response subsequently causes adhesions, facial thickening, and cause changes in the vasculature and also formation of scar tissues. Kaufman agrees they actually, in 14 patients with chronic diabetic paralysis post-interscalene block, they found that there's scar tissues, vascular changes, adhesions around the phrenic nerve, which suggestive of chronic inflammatory changes. And animal studies has also shown that ultrasound gel itself if it goes inside and into the peripheral nerves, can cause inflammation. So whenever there's neural hypoxia, whatever causes neural hypoxia, this can cause inflammatory changes and causes activation of the resident in the neural macrophages. And these macrophages will release this vascular endothelial growth factor. So vascular VEGF. VEGF is a potent inducer of formation of new vessels, and these new vessels actually are not, it doesn't have this tight junction, so increase the permeability and causes a breach of the blood nerve barrier. And hypoxia itself can also impair the autophagy of the nerve, which subsequently will lead to hemostatic dysfunction. When there's inflammatory changes as well, there'll be degranulating, increase in degranulating mast cells, which release inflammation such as histamine and serotonin and ATP.
I'll be presenting on etiology of peripheral nerve injury. Etiology of peripheral nerve injury. Determining the causation in the setting of surgery and regional anesthesia can be challenging as these factors are compounding. Etiology of PNI can be multifactorial. It includes anesthetic, surgical, and also patient factors. So for the anesthetic factors can be divided into intraneural injection, nerve structure, and also usage of the needle. Needle type. So for the intraneural injection, intravesicular intraneural injection can cause greater peripheral nerve injury. This is due to the exposure of axons to high concentration of LA. High opening pressure injection and also abrupt needle advancement lead to high risk of peripheral nerve injury. Nerve structure. Structural organization of peripheral nerve provides an insight to relative risk of mechanical injury. Proximal peripheral nerve, which has higher vesicular to connective tissue content, has higher risk of peripheral nerve injury compared to the distal peripheral nerve. This can be seen in proximal brachial plexus block versus tibial nerve block. So in proximal brachial plexus block, it has higher vesicular to connective tissue content, therefore has a higher risk of peripheral nerve injury compared to the tibial nerve block. Epineurum is typically tougher layer compared to the surrounding tissue, therefore nerves tend to be pushed away by advancing needle. However, abrupt pressure may lead to needle to penetrate into the intervesicular plane, causing risk of injury. Needle type. Short beveled needle compared to the long beveled needle are less likely to penetrate the epineurum and perineurium of the peripheral nerve. Therefore, it shows a better safety profile. However, intravesicular injection of short beveled needle is more severe compared to the long beveled needle. Increase in diameter, needle diameter, and also usage of the pencil to hinge point needle increases the injury as well. Surgical factors. Surgical positioning of a patient that involves traction and compression can cause physical disruption of the intraneural blood vessel, thus causing myelin displacement and axonal degeneration. Loss of muscle tone during general anesthesia also exposes neural elements to traction forces, therefore increases the risk of injury. Usage of pneumatic cuff, pneumatic tourniquet causes nerve damage by mechanical injury or ischemic injury. Tourniquet neuropathy includes motor loss, diminished touch, vibration, and position, signs with preserved heat, cold, and pain. Patient factors. Presence of preoperative neurological deficit or neural compromise increase the risk of perioperative peripheral nerve injury. Perioperative neural compromise, example, entrapment neuropathies, diabetic neuropathies increases the risk of neural damage post-block. In diabetic neuropathies, chronic ischemia may compromise diabetic nerve root, thus renders them susceptible to LA toxicity. Medical conditions such as peripheral vascular disease, vasculitis, hypertension have adverse effect on the microvascular nature of peripheral nerve. Thus, it increases the risk of injury as well. How do we minimize peripheral nerve injury? It is suggested that combination of nerve stimulation, ultrasound, and pressure monitoring, referred to as triple monitoring technique, may be beneficial but remains to be proven. Ultrasound technique. Advantages of using an ultrasound include its ability to visualize the injected and detection of nerve swelling. However, it also has its disadvantages, which include its inability to visualize clearly inter and also intravesicular needle tip location. So incident of PNI, it is proven that incident of PNI has not changed with ultrasound usage, and it is operator and also patient dependent. So these are the strategies that are being used to improve the needle tip visualization on ultrasound. So it includes the needle design, needle beam angle, needle bevel orientation, and also needle diameter. So usage of the echogenic needle improves the visualization better on ultrasound. The angle, needle beam angle, the angle at which needle shaft and also ultrasound beam intersect. An in-plane approach has a better visualization, has a reduced risk of peripheral nerve injury. Needle bevel orientation. Visibility improves when bevel opening is directed towards the face of the ultrasound beam, which is 0 degree, or face 180 degrees away from the beam. Needle diameter. Larger diameter at the expense of increased tissue and neurotrauma and also patient discomfort. So usage of larger diameter also improves the visualization, but at the expense of nerve injury. Hydrolocalization, hydrodissection. A small volume of injectate is delivered at which act as a surrogate marker of the needle tip position. So usage of hydrodissection, hydrolocalization also improves the also reduces the nerve injury as well, as it opens up the space between the structure. So peripheral nerve stimulation, it doesn't predict tip to nerve location as accurately. So motor response of a current less than 0.2 milliampere is highly specific for intraneural needle placement, but not as sensitive as more than 1 milliampere, as it can still produce motor response with a current of more than 1 milliampere. Needle need to be repositioned if motor response obtained with a current less than 0.2 milliampere. So nerve stimulation with current intensity of 0.2 milliampere to 0.5 milliampere with pulse duration of 0.1 millisecond indicates a needle to nerve position that is safe for LA placement. Injection pressure monitoring. Avoidance of high injection pressure postulated at 15 psi is likely to improve safety. A low opening pressure less than 15 psi indicates an extravesicular or extraneural injection. High opening injection pressure more than 15 psi may be a consequence of an intraneural intravesicular injection of the needle. Paresthesia. Severe paresthesia or pain or needle advancement or injection may imply intraneural placement. So therefore, once patient felt paresthesia, needle should be repositioned and immediate cessation should be done. Factors such as sedation, comorbidities such as peripheral neuropathy, the patient's ability to perceive pain, and sensory blockade from the local anesthetic can affect the evaluation of paresthesia. However, absence of paresthesia does not exclude nerve injury. Planning a trajectory. Some structures does not appear on ultrasound as clearly, so caution must be taken when choosing a potential needle trajectory. Using hydrodissection to open up needle trajectory route may displace the structure, thus improves the visualization. Reducing the number of passes required to achieve a spread also reduces the likelihood of injury. So from this picture, we can say that planning a trajectory is quite important. As we can see, number 1 is the common peroneal nerve, whereas number 2 is the tibial nerve. So common peroneal nerve is mostly not as visible as the tibial nerve. Therefore, planning a trajectory avoiding the common peroneal nerve is very much important to preserve the nerve function. So in this picture, we can see that choosing a pathway 4 is a better option compared to the oblique pathway of 3. Avoiding intraneural injection, aiming the needle extraneurally outside the outer border epineurum of the nerve, but still under the connective tissue will provide a safe and effective anesthesia. A low pressure injected into the area between the epineurum and connective tissue results in hydrodissection, which allows safe movement of the needle. As we can see here, usage of the hydrodissection can allow and improves the technique of can allow a better visualization. So aiming it extraneurally with the needle tip for a popliteal sciatic nerve block with good spread of local anesthetic between the epineurum and connective tissue. So ultrasound, a low pressure injected into the area between the epineurum and connective tissue should result in a hydrodissection. Thus, it allows better visualization of the area.
Moving on to the diagnosis and management of peripheral nerve injury. The algorithm shown in this slide is an outline of the management of nerve injury associated with peripheral nerve block, published by Regional Anaesthesia of United Kingdom in 2015. When the patient has a new onset of pain, weakness, numbness, paresthesia, or other abnormal sensation, or if the effects lasting beyond the usual duration of a specific block, which is more than 48 hours, then the patient will normally be referred to the regional team for assessment. When we review the patients, we will have to take some relevant medical and surgical history to elicit if the nerve injury is associated with our peripheral nerve blockade. We need to ask the patient if the patient has any peripheral neuropathy, which will influence their normal sensation of that part of their limb. And then also ask the patient where is the site of the pain, where is the weakness, whether the weakness is associated with which nerve supply, or where is the numbness or paresthesia related to which dermatome or which nerve, and has it been progressively worsening, or what is the degree of the numbness or the so-called paresthesia. And then we need to have a look at the operation notes to see if the surgery was a complex or complicated surgery, any nerve injury that could have happened during the surgery, any traction of the nerve, and where is the site of the surgery. And then we also have to have a review of our anesthetic records and have a look at when was the peripheral nerve blockade done, what was the needle used, whether what kind of modalities have been used to aid our peripheral nerve blockade, for example, ultrasound or nerve stimulation. What was the concentration of the local anesthesia and volume used? And whether the patient have already had a neurological deficit prior to our peripheral nerve blockade is also important. Next, we will need to examine the patient and to do a full, thorough neurological examination to assess the site of the complaint. And at the same time, during our assessment, we need to rule out a certain reversible pathologies, for example, compartment syndrome that requires an urgent surgical intervention, any surgical nerve transaction that could have caused the nerve injury, any external compression by the patient's cast, or any hematoma as a result of the surgery. Once we have ruled out the reversible pathology and find out that the patient is actually having just a mild symptom or resolving symptom, or if the patient has only sensory deficit, then the next step of management is to reassure the patient and have the patient review in 4 weeks' time. And after these 4 weeks, if let's say the patient is still having persistent symptoms, then we will refer this patient to neurological team to further work up for nerve injury. However, if the symptoms have already resolved after 4 weeks, then no further follow-up is required. On another part of this algorithm, if in our assessment we have found out that the patient has any motor involvement, any progressive neurological deficit, or if there is a complete absence of nerve function beyond the duration of peripheral nerve blockade or incomplete injuries with moderate to severe functional limitations, then this patient will have to be referred to the neuromedical team or the neuro team to further work up for nerve injury. The investigations that will be done to assess a nerve injury involves a neurophysiological study. A neurophysiological study will include a nerve conduction study and an electromyography. For nerve conduction studies, it's actually used to assess electrical conduction impulses along a nerve. As you can see in the diagram, this is actually how a nerve conduction study is done to assess a motor nerve. Hence, the stimulation is provided at a more proximal part, and then the stimulation electrode at the place where you want to examine the motor nerve, and then a recording electrode will be placed in a more distal region. However, if you are assessing a sensory nerve, then the electrodes will have to be placed in a reverse direction. A nerve conduction study can localize the site of a conduction block and confirm whether the site of the lesion is at the site of our peripheral nerve block. And it can also determine the degree of injury and classify our nerve injury. When a stimulus is placed, the stimulation will go across the nerve that we want to examine, and it will provide a graph, as you can see in the diagram on the right side. Once a stimulus is placed, there will be a latency between a stimulus and the evoked response. And then the evoked response will provide an amplitude of voltage signifying the strength of the evoked response. And then the distance of this response will be divided by the time and produce a conduction velocity. In a neuropraxia, this is a table that shows the result of a nerve conduction study in a sensory nerve. In neuropraxia, if at a lesion proximal to it, you can see that the latency is increased, the conduction velocity is reduced, and the amplitude will be reduced. However, distal to the lesion, where it is not affected, then the latency, conduction velocity, and amplitude will be normal. However, in axonomesis and neuromesis, because there is already a loss of continuity of the axons, the conduction will not be able to pass through, and hence there will be absent in all the latency, conduction velocity, and amplitude of the nerve. Next is electromyography, which is the EMG. It studies the electrical activity generated within a muscle, and it will determine the muscle units affected by the injury and determine if there is a nerve continuity. The EMG involves inserting a needle through the skin into the muscle, and it is normally performed at least 4 weeks after a nerve injury. This is because evidence of denervation is indicated by presence of fibrillation in the muscle, and this will only be apparent after 4 to 6 weeks of injury. So basically for EMG, the thing that we are actually looking for is the muscle fibrillation if there is a nerve injury. For neuropraxia, normally it will not result in a muscle fibrillation. However, after 4 weeks of nerve injury, when there is an axonomesis or neuromesis, after a stimulation, we will normally be able to see muscle fibrillation in the study. Apart from neurophysiological study, we can also do some imaging to guide us into whether this patient is having a nerve injury. The most common imaging modality used is the MRI, and MR myelography, MR neurography, or diffusion tensor imaging are the MRI modalities used to study nerve. Nerve signal will increase significantly following a traumatic nerve injury, resulting in high contrast of the bright nerve, which is a hyperintensity against the surrounding muscle or fat. The increased nerve signal due to axonal degeneration can be observed at the site of injury and distal to it. This is for us to localize the site of the nerve injury, but it can also not be specific. Some other imaging that we can use to examine the nerve injury is high resolution ultrasound. After diagnosing a nerve injury, then we will move on to the management. It is important to note that at the moment, there is no pharmacological therapy that has demonstrated to enhance neurogeneration. However, we can refer the patient to physiotherapy to help maintain the muscle mass and prevent flexion contractures. We can also prescribe some analgesics to help ease the pain as a result of the nerve injury. And these analgesics will normally include neuropathic analgesics. If the nerve injury is severe or can be subjected to surgical intervention, then they will be referred to the relevant team to do nerve repair or nerve grafting. Finally, we should also maintain communication with the patient and reassure them, give them empathy, and follow up as appropriate.